Good evening, everyone, and thank you for joining us tonight for our annual Triage education session, especially for reception and admin staff. My name is Fleur Niven from the Practice Support and Development team. I also have my legendary colleagues Evelina and Bertha with us tonight. Importantly, I would like to start tonight by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community and pay respect to elders past and present. I also extend that respect to any Aboriginal colleagues who may be joining us tonight. Okay, now for the reason we are all here tonight. I'm pleased to introduce Angela Mason-Lynch, Risk Advisor for Avant, a registered nurse and certified practice manager, popular presenter and educator. For me, Angela has walked the talk and understands general practice completely. Now, over to you, Angela.
Thank you, Fleur, and thank you very much, Central and Eastern Sydney PHN, for inviting me. So I hope I also have online tonight Julie Cowap, who's one of my colleagues, and she's the legs of Avant. She'll come out to your practice and drop off any resources if you want them. So Julie, I can't see you. Oh, there she is. You might want to turn your camera on, Julie, and wave. But Julie's great. She has got all the information that you will need after tonight. So I'm going to talk to you about triage, and you might think, gosh, why are we going down this path again? We've been hearing about it for years, but I think we've had a pretty huge change in our landscape recently with COVID, but also for a lot of other reasons. There's a lot of laws that have changed, and I think credibility for our profession has declined quite substantially, and patients are really worried that you are not managing them properly. I know we seem to have seen a real increase in the fact that they don't think they don't trust you to be looking after them properly. They're really quick to make a complaint directly to a regulatory body instead of to you. And anytime you get a complaint, it's really time consuming for you. We've recently done a study of all the claims that practices have made, and something like 1 in 14 practices have a claim against them, and that's an official claim. And something like about 46% of those were claims about the receptionists or the support staff poor communication skills, and particularly poor communication skills in getting them access to the doctors. So that makes me think that probably the way that you're communicating about access to doctors, the way you're triaging, you're not sharing that with the patients properly. We're also managing at the moment a lot of claims around delayed diagnosis, and a lot of the reasons that patients are saying that they're getting this delayed diagnosis is because the practice isn't allowing them to get an appointment soon enough, so their problem has become urgent before they get to the doctor, and also because they have felt that they couldn't come to the doctor because they haven't felt safe. So you're damned if you do and you're damned if you don't. Tonight I'm going to try and break down some of the barriers and give you some strategies and some words that you can use so that hopefully you don't get a claim. But if you do get a claim, hopefully we'll be able to defend you, because the minute something happens, and hopefully you, if you're a member of ours, you'll contact us straight away, and we're going to ask you for a whole lot of information, because if you get a complaint, we want to stop it from going any further than where it is at the moment. So we're going to start asking you for evidence so that we can respond to wherever this complaint's gone, so that it doesn't end up with APRA. So look, It's really difficult in general practice at the moment because the standards are what you're measured against. So you have to have a triage protocol when you get accredited, and it does say a practice-specific triage protocol. So that's what the standards say, and that's something that would be assessed if you have a claim against you. You're also bound, because you're working vicariously for medical practitioners, you inherit the responsibility that they have in acting in the best interest of your patient. This is their code of conduct. So when a claim is made, even if it's about the practice, they'll measure you against the standards, but they'll also look at whether or not this doctor that you're working vicariously for, whether that doctor is meeting his or her responsibilities under the code of conduct. And that code of conduct basically says doctors must manage patients needing their care. Interesting, isn't it? Because you've got abusive patients out there that you might want to ban from the practice. So you've got to manage the doctor's responsibility here as well, which is a whole nother presentation. But I just want you to understand that by working vicariously for the doctors, you've got to be having the patient's best interests at heart, unless there's a real reason for that not to happen. It's also really difficult for you as a worker because you have an obligation to keep you and your workplace safe. So that includes things like not overbooking your doctors, because then the practice isn't going to be able to practice safely, is it? It means that you have to screen patients properly because you need to keep other patients and yourself safe in the workplace. And you have to be thinking about that all the time. That's your responsibility for workplace safety. So you have to be thinking about that when you're writing your triage protocol, because you've got to work out what you have to know to make sure that you can best manage these patients, but also keep the workplace safe and keep them safe. We've already talked about those increases in claims with delayed diagnosis. But I guess the biggest thing that we've seen is patients saying the receptionist didn't explain it to me, or the receptionist was rude, or the receptionist didn't care. And often we see that inflames the patient, and then you have an angry patient on your hands as well, which makes your job even harder. I've got a little questionnaire I want you to do right now. Can we get this one answered, Fleur, and you tell me the answers? So when was the last time you reviewed your triage protocol to ensure it was relevant to your practice? Did you do it last month? When COVID hit? Did you do it a long time ago, or you can't remember? Or are you about to review it? So if you wouldn't mind answering that question.
I'm just watching them come up. We're out of 31% answered. Come on, late team. We can all click a bit faster. 50% have answered. It's a bit neck and neck.
Yep.
We've seemed to have leveled off at 63%. Are we going to have any more participants? No. Okay. So in the last month, we've got 29%. COVID hit, 25%. Can't remember, long time, 21, and we're about to. Yay, that means you're going to be armed with tonight's information as well, I guess. Okay, thank you.
That's fantastic. Thanks, Fleur. Look, I really love the people that wrote in the last month. That's fantastic. I'm hoping that was because of a few changes that have happened. We've had the new RACGP infection prevention guidelines released. They were released in March. So this should automatically prompt you to review your triage protocol. A lot of practices did it during COVID, and and then they've got really busy since then. So it hasn't been done again. I accept that. It does bother me that some of you said a long time ago, or I can't remember, because I'm wondering if these are if you answered that, then you are at risk of having a very out-of-date triage protocol. And I absolutely really love all of you that said you're about to do it. So hopefully after tonight, you won't be too daunted by what you've got to do. The one thing that I would like to say here is, if you have a claim or a complaint raised about a delayed diagnosis or an adverse event, and to give you an example, I dealt with one just last week where a patient rang to try and get an appointment, and the receptionist said the next appointment is not for 3 weeks, and they ended up in having to get an ambulance to the hospital, and they made a claim against the practice. Now, that made me wonder what actually happened on that original phone call, that the patient felt that they couldn't tell you what they needed and you couldn't direct them a little bit better on what they should have done. So what I wanted to say here is, when that happens, and we want to defend you, we want to show that you're reviewing your triage protocol all the time. So we want to actually see the old copies. If any of you have got Practice Hub, that's managed really well because they keep the old versions. If you haven't got something like Practice Hub, you obviously will have a policy and procedure manual. Just make sure that you keep the old ones, because often we get claims, 3-6 months later, and we want to go back and look at your triage protocol then, and we want to be able to show the regulatory bodies that you've reviewed it and that you review it quite regularly. So that's a really important, what we call, defense building block for us, to keep your old copies of triage. I want you to think about, when you're developing your triage protocol and administering it, so when you're actually, working it, I want you to think about the responsibilities as a health provider. So you can't just say no to a patient. You need to be strategizing what you can do for them. So unless, of course, they've been banned, which is a whole different scenario. But basically, if you've got a patient ringing you, you have a responsibility, working vicariously for your doctors, to work something out with them so that their needs are met, their healthcare needs are met. But there might be other things that you have to think about as well. There's other, what we call, internal influences that you need to think about. So you might have a really high quantity, high numbers of children visiting your practice, or high numbers of patients who are immunocompromised. Or you might have a handful of really smelly patients, or patients with low white cell count, or, really important one, a high number of mental health patients. These are all what we call internal influences that will affect your triage protocol. So you've got to somehow flesh out whether you've got that person on the other end of the phone so that you can triage them properly. And this means that you must ask the questions that you need to know, so that you can rate the urgency of those patients, taking into consideration you've got to care for the patient, and you need to be aware of these internal influences. You need to also be aware of the external influences. So what I'm talking about there is things like, have you got an outbreak of the flu in your area at the moment, or COVID? Or have you been told that there's a lot of shingles around your area at the moment? Those things are really important external influences that you need to be thinking about when you're deciding on what you're going to do with a patient, and how you're going to take care of them, but take care of yourself and the rest of the patients sitting in the waiting room. Just little simple things like making sure you can actually administer your triage protocol. So making sure, if you have got an urgent patient, that you can actually do something with it. So, I get really surprised at practices when I hear that when you open up your doors on Monday morning that you're already fully booked. Like, how can you not be thinking on Monday morning you're going to have some urgent appointments? And then what do you do with them when they do ring? And even if you're reserving appointments and not opening them up to on the day, they will still often get booked out really quickly as well. So patients have worked out by now that if they ring up, or if they book online, at 10 minutes before you open, that they're probably going to get an appointment. They're going to start doing that, and they're going to start taking those on the day appointments with things that can probably wait another couple of days. So even if you're reserving appointments for on the day, have a block there as well that you can also especially reserve for those times when you are running out of those urgent appointments, and only you know what your practice is like. The other thing that you want to really think about is with those internal influences, how are you going to know? Because you're administrators, how are you going to know if a patient is immunocompromised or pregnant or has cystic fibrosis, which needs to be treated a little bit differently? So mental health is another big one. What we recommend is that you somehow mark the file. So as soon as you're in a conversation with this patient, there's something that pops up that alerts you that this patient has to have special consideration because there's an influence that's going to make you triage this patient a little bit different. So how are your files marked? Who keeps the list? How do you access them? Who adds to the list? Who takes people off the list? What are the reasons for people being on that list? So again, only you know this because your practice is very different from a practice in rural New South Wales or a practice in, for example, the eastern suburbs practice might be quite different from a practice at Burwood. So we often see that it's not clear when patients should be triaged a certain way because of an internal influence. Also have a little think here as well about patients that have been banned from your practice. And again, please contact us if you are wanting to ban patients, because you just can't ban them. There's got to be a good reason, and you've got to have a process for that as well. But if you've got a patient that's banned, are they tagged so that they can't take any of your appointments? And how are they stopped from making an online appointment? Consider those local areas, which we've already talked about. And also remember that you might be the first, you might actually be identifying an outbreak in your area. So keep in mind some of the answers that you're getting to some of your triage questions that you might want to report back to your people and discuss whether or not, there's something that's happening out there in your community that could affect the way that you triage or the way that you prioritize appointments. The other thing I want to talk about is the fourth point here is, how do you let your patients know? How do you keep them informed? Because I just do not think we do this very well. What have you got on your website that helps them understand why they have to wear a mask, or why they have to do something that you want them to do as a condition of entry into your practice? Because most of the patients that make complaints, they make complaints because they don't feel like they were warned properly. They didn't understand the why and what's in it for them. What's in it for them? If you won't squeeze them in for an appointment, if they're not urgent, what's in it for them if you're going to decide that their appointment isn't going to be this week, it's going to be next week. Help them understand the why. And don't forget also that if they understand why, they're more likely to comply. Okay, just so long as you do, make sure you're not going to sleep. I've got another poll question, Fleur. This one's about how would you manage a patient with a cough and a possible chest infection? So this is a patient that's phoned you and you've asked them the questions, have you got a cough? And they've said yes, and I think I've got a chest infection. I keep coughing up stuff. What would you do with this appointment?
Okay, we're getting action. 12, 20, 24, 30. More answers this time around. We're past 50%.
Ooh.
Okay. Still moving. Okay. Well, we can see at 59% answered, that the management is we would follow our protocol for high risk infections, and that's 71%.
Well, you know what? I'm so proud of all of you. That is the most correct answer. The reason that you wouldn't automatically put this person in a telehealth consultation is because, just like everything, we're getting lots of Medicare audits on telehealth, and there is certain rules around when a telehealth consultation is appropriate. And we've seen way too often that the receptionist makes a decision about a telehealth consultation and then it really shouldn't be. And it's just really a waste of the doctor's time, because they can't charge for both a telehealth consultation and a face-to-face consultation if they have to do it. And if a patient needs an antibiotic, they probably shouldn't get it just with a telehealth consultation. The medical board would want to see that the doctor has listened to the patient's chest and actually been, it's been confirmed that that patient has a chest infection. That's what we call antibiotic stewardship, or antimicrobial stewardship. So the medical board are really looking at antibiotic scripts these days and making sure that they're only supplied scripts if it's warranted. So, you might want to think about, when is a telehealth consultation not okay and when is it okay? Now, what you might have a deal with your doctors where they say, yeah, book it as telehealth and then I'll make the decision when I talk to the patient. But you might want to just have a bit of a conversation about that when you're talking about your triage protocol. I like that none of you said we would not accept them as they could have COVID, because during COVID, a lot of patients were rejected, and that's where a lot of the claims are coming from now, because they said they couldn't get care because they were suspected as having COVID. So thank you very much for not answering that and not saying yes to that. All our patients wear masks, so would be treated the same as, that's interesting. We know that masks don't really do 100% protection, but they do help. And certainly it's still a good strategy to ask patients to wear masks, but you'd need to be doing a lot more than that. And of course, I loved your final D answer, which a lot of different practices came up with different ideas for seeing high-risk infectious patients, such as seeing them in the car, seeing them at the back door, seeing them, of an evening when no one else is around and you're in full PPE. There's lots of ways that you can see an infectious patient, because this goes back to the medical practitioner's responsibility to see a patient or to care for a patient if they are sick. One thing I will mention, just in regards to a telehealth consultation. So this was a matter I dealt with just recently, where a patient was phoned to say he needed a consultation because the doctor had received a letter back from the specialist, and the patient said, "Oh, could I do it by telehealth?" And the receptionist said, "Yeah, sure," booked it in. And then the telehealth consultation was booked. The doctor rang the patient on his mobile. He did actually say to the patient, "This is Dr. Smith, are you okay to have your consultation?" And the patient said yes. And then the doctor proceeded to tell the patient that he'd received a letter from his cardiologist, and the cardiologist had said he had to stop his Viagra until they'd had done some more cardiac tests. Now, the consultation, the patient was in his car, and with him in his car was his son and his son's best mates, two best mates. He was taking them to football training. So there ended up being a claim against this. And the question was asked, even though the doctor had confirmed that the patient could proceed, that wasn't documented well. So that was one problem. But the medical board also said to the practice, well, what is your process for triaging telehealth consultations? When can you do it? When can't you do it? What do you tell your patient when you're booking this? Because you're the administrator. What are you telling the patient when you're booking a telehealth consult so that they can be private? So that's very, very important. So moving on, let's talk about how you do assess patients. So basically, you're observers. You're going to observe them, and that might be even if they're talking to you on the phone. You can listen to the way they're talking. If they're face to face, you can look at them and you can see, you know, how they're looking and whether or not they look like they're really sick or whether they're looking okay. So that's one way that you can kind of get a bit of an idea. That can be quite easy for somebody that's been working support for doctors for a long time, but it can be quite tricky for a younger person who's fairly new to the role. So that is something that you need to think about. You know, what are your observation views, and how can you get more information or more help with improving your observation skills? The best way that you can screen patients is with questions and you know, really listening to the answers. And then, of course, having some history or notes on file. Now, I'm not talking about, and I dealt with a case recently where a receptionist was going in and reading all about the patient's history before they'd make an appointment. That's not appropriate. But what is appropriate is if you've just got a little note on the file, something like you might even tag the file a certain way so that you know these are a high priority, must book in the next 12 hours or something like that. So those sorts of things you need to be thinking about looking at. Look, I can't stress enough the importance of immediately putting a patient on hold. If you pick up that phone, please just do an initial, are you okay? Are you okay if I put you on hold? Because that's where the patient's going to go, you know, no, I'm not, I can't breathe. And then you can say, okay, you need to call an ambulance. That's all of a sudden become really important. Happens all the time where receptionists don't actually ask a question before they put them on hold. The other thing that I find that happens an awful lot is the receptionist the receptionist answers the phone and the patient says, oh, I need to make an appointment. And the receptionist just goes straight into, okay, Dr. Smith's next appointment is in 3 weeks' time. That is actually not okay. And if that patient took that appointment in 3 weeks' time and then ended up having an adverse event and made a claim against your practice, you would be questioned by the medical board about whether or not your system is okay, and they would say it's not, because you're not asking those basic questions. Is it urgent? Or, you know, what is the problem? How can I help you more? And you need to be careful, and I'll talk about how you ask those questions later, but you definitely need to ask more. You need to do more than just say, okay, the next appointment is in 3 months' time, 3 weeks' time. The other thing that I find happens is sometimes a receptionist, good on them, might say, is it urgent? And the patient says, oh, no. Then the next thing the receptionist says, they go, oh, great, it's not urgent, terrific. Okay, when would you like it? Again, that's not the right answer, because remember, we've already talked about, you know, identifying when your busy periods are, like Monday morning, for example. So don't put your non-urgents on Monday morning. Keep Mondays as free as possible. You know, for your practice, it might be Wednesdays are your days when you need to keep it free because you've only got one doctor on that day. So they're going to book out more quickly. You know, there's reasons that you might decide that, you know, non-urgent appointments, if you've got a patient that's not wanting the appointment today and they're able to wait, it's not urgent, then, you know, you decide where you think that they should fit into your schedule. The other thing, it's often, practices often say to me, how many damn questions do you want us to ask? And again, the most important thing is to have just a couple of questions so that you don't have to be reading your triage protocol, because you're not going to have time to be reading everything. So just have a couple of key questions that are really important to you, and I'll show you how you work that out. how you work that out later. But don't forget, those key questions could change if something happens. Like if you're having an outbreak of COVID in your area, you might ask more specific questions about that. Like, do you have a fever? Do you have a cough? And things like that. If you do have a chance, one of the links we'll send you around is the link to the updated RACGP infection control triage protocol. And it's really quite interesting, some of the suggestions they have about what you should and shouldn't say. Don't forget about those special needs patients and the special needs of team members, things like your mental health patients, your infectious patients, your at-risk patients. Think about how you're going to identify them. Think about who they are. And this is a group exercise that you're going to do when you are designing your triage protocol. Think about which patients are these special needs patients, the patients that really you need to get in as soon as possible to, within the next 8 hours or something like that. Think about what you can do as well. So you need to stay current yourself, and remember that your triage protocol needs to be a little bit fluid. You need to be able to think outside the triage protocol sometimes, because you're not going to slot people straight in. And there's going to be these external influences that happen all the time. So think about what you can do, the different types of things that you can do with a special need patient that you don't want in the practice at a certain time. And to give you a perfect example, I worked with a practice who had it was a high demographic. So it was an area where there were quite wealthy patients coming to the practice and paying a lot for their consultation. But then this practice also had felt that they wanted to serve the needs of the disabled patients in the community as well. So they also saw quite a big cohort of disabled patients. And it became quite tricky for their practice to see the disabled patient at the same time as seeing, somebody that's paying $120 for a standard consultation. So they had to think about, because the disabled patient might be incontinent, have Tourette's, and not have been able to shower for the last week. So the practice had to sit down and work out, what can we do in our practice so we can still charge $120 for a consult for those patients that can afford it, and we can still serve the community by seeing the disabled patients. And what they decided was that they would see the disabled patients in certain scheduled times. And that worked really well for the practice. My point here is that you need to work out together with your team what's going to work best for your cohort of patients, because they will be really different. In some practices, a sick child will be top of the list straight away. So the first question you might ask is it a child? And if it is, well, top of the list. That's where that's your special need patient. You might be a practice where eye injuries are a really big deal. So that's all of a sudden at the top of the list. So this is what I'm talking about with having specific areas of urgency for your specific practice. But then you'll have the, standard stuff like pallor, bleeding, a patient that's fainted or something like that. All those things will sit in there as well. The other thing I just want you to think about when we're talking about special needs patients is, when do you call 000? When do you say, we can't accommodate this patient and the best thing for this patient is to go to hospital or call an ambulance? Who makes that call? And I've seen this done a whole lot of different ways. So sometimes it's always the nurse or the doctor that makes that. Occasionally I've seen where a receptionist has the ability to do that. And, what criteria, what things they have to ask to make sure that, they are ensuring that an ambulance is only called if this patient really needs it. And that might be an ambulance that you've organised from the patient's home to hospital, but it also might be an ambulance that you've got coming to the practice. If you do have the benefit of a nurse working in your practice, really good idea to somehow work them into the triage protocol. Also, if you have an MPA, a medical practice assistant, they can sometimes have that little bit more of a clinical perspective, and they'll be able to help you triage your patients a little bit better. I worked with a practice once who it was actually a really dreadful scenario where a patient, he was actually he had been in prison. He was a very aggressive male patient who was very large, and he had a mental health disorder. And he managed to get the last appointment of the day when there was only one female doctor on and one receptionist who was busy sort of balancing the till and so on. And I thought, a typical example of a special need that really needed, that file needed to be tagged so that situation couldn't happen. So those are the types of things you need to be aware of. And you might be saying, well, we don't know about that. That's the doctor. And this is why it's really important that the doctors get involved in your triage protocol, even if you guys decide on it and then show it to your practitioners to sign off on. I think that's all I wanted to say there. Okay, just some of the things that you need to think about, and this is kind of part of triage, because remember, triage is about protecting your patients, protecting other patients in the practice, and protecting yourselves. So, you might be so sick of PPE, but it is about keeping you safe. And if there's if a patient makes a claim that they don't feel safe coming to your practice and so they couldn't get care, and we've had those, then these are the sorts of things that the regulatory body will want us to look at. So, what sort of PPE are you wearing? What's your hand hygiene and your cough etiquette? Make sure that there's some sort of a policy for not coming to work when you're sick, and notifying your team leader if you're concerned about yourself in any way, or your personal safety in any way. And that might be an aggressive patient as well, so then we go back to them being a special needs patient. So how do we manage this aggressive patient? If we don't want to just ban them, which, as I said, is a process, then what are you going to do so that you're safe? You protect yourself by designing the best questions to screen your visitors and by educating your patients. Let's get into the nitty-gritties now. So this is about how you actually design your triage protocol. Now, remember that your triage protocol is not just about finding out the patients that really need help quickly. That was triage years ago. That's not what triage means anymore. All triage means is a system for prioritizing your appointment scheduling. So working out what you need to see now and what you can see in 3 months' time. So that's what it's all about. So what you can see now, what you see in, say, 3 months' time, and everything in between. So you've got to know what's urgent. You've got to know how you're going to recognize it's urgent. You've got to know what training you need to have so that you can recognize and you can make your triage protocol fluid, what the capabilities are at the practice. And this is really important, because if you've got a broken ECG machine and no nurse on today, that might change what you do. You can have the best darn triage protocol, and all of a sudden there's some internal influence, like your nurse is sick or all your doctors are off except for one, and the whole triage protocol has to be manipulated a little bit for the day. I don't expect you to rewrite it on the day. I just want you to be thinking that you can have the best protocol written down and it might change a little bit because of something that happens. Think about how you might involve your nurse, and make sure you are very clear about who rings 000 and how that system all works. Who's the one that makes that call? Who actually decides that the call should be made? And how does the process work once an ambulance is called? Who looks after the patient until the ambulance gets there, and so on? Or how do you check if you've rung the ambulance to go to a patient's home? How do you check that they've actually got to the home and got the patient into the hospital? Don't forget your low priority patients, so your non-urgent. Be really, really, what's the word I'm looking for? Be safe about the time that you will give a non-urgent appointment. So I've seen doctors have a non-urgent appointment, push out to 3 months' time. Now, if you're going to do that, you also need to think that that appointment might become urgent before then. So, something like a pap smear is not going to all of a sudden become urgent. But if the patient needs a referral for a specialist, it might become urgent in a 3 month period. So you might want to think, if you're going to push out your non-urgent appointments for 3 months, well, then you might want to say, okay, what other questions do we have to ask, or what else do we have to say to the patient, so that you can inform them, to ring you if it becomes urgent within that 3 months. So be really clear about how long is a non-urgent appointment. It might be 3 months, might be 2 weeks, depending on your practice. And it might even be different from from practitioner to practitioner. Some of your doctors might be really busy and others aren't as busy. Some of the urgent issues that will come from left field will be critically ill patients, and you'll have to work out who are your critically ill patients, your infectious patients, your aggressive patients, or your mentally ill patients. They're patients that might need to be seen urgently. I'm just going to go in now to what your triage protocol might look like. So it's really great if you can keep it on one page. A lot of you have used those PHN pop-ups, and I'm going to show you the one that Central and Eastern Sydney PHN, a lot of you will have already. I like them, but remember, it's got to be practice specific. So I usually use those ones that are designed externally as a bit of a guide for you to decide yours. So basically what you have is a bit of a flow chart. And we're going to go through this, so don't stress too much about it. You have 4 to 8 columns with titles, and that's your capabilities. And then you have what those columns are actually, what they actually mean. And then you might have some diagnosis or possible diagnosis in the columns, and then you have your questions to help put people in the columns. So we'll go through that in a little bit more detail shortly. So I've got another poll question here. So I want you to decide if this is a high priority appointment or not. So mother of Stephen calls, he has a sore toe and he wants an appointment. So is this a high priority? Yes, no, or it depends.
Okay, we're going faster. Everybody's getting practice. We're up to 44, 54. And come on, we want to get up to 64. Come on, come on. Yes, we've passed it, and are we going to get to 74? Oh, I think we might. One more, please. Okay. Depends.
Oh,
yay. Yay. Phew. Okay.
Okay, so interesting. I love somebody said, yes, I bet that's a practice that all children are a high priority. And that's great.
I wonder if there was an assumption because of the little baby feet, which is an assumption.
Good point. But guess what? I was tricking you, because I'll tell you, when I was actually working in a practice, I had a mum ring up once and say, I'd just like to make an appointment for my son. And the receptionist said, yeah, sure, okay. And we had, in that practice, we had the same policy that all children are seen in the next available appointment within 24 hours. And but her son was 35 and he was at work, and she was ringing for him because he couldn't get away from work. So I guess the answer is, you can't assume that it's not. Now, let me tell you this scenario. So Stephen was actually a little, I think he was 4, around about that age. And his mum was not terribly smart. And so this receptionist said, okay, what's the matter with his toe? And she went, oh, well, he's wrapped something around it. Looks like string, and it's kind of gone dark blue. Now, all of a sudden, this is a damn urgent appointment, isn't it? So it was only asking that extra question that helped the receptionist do the right thing. Because remember that the patient you've got on the other end of the phone, you have no idea how terrified they are of going to the doctor, how smart they are, how, whether they're just an anxious mum. All these things you're not going to know. So you have to assume, unless you've got a very small practice where you know your patients really well, you're going to have to assume you have to get more questions to make sure that you actually triage this patient properly. So very much it depends on what the answers to the next questions are as to whether this is an urgent appointment or not. This was another interesting scenario. This was it was actually the hospital had phoned this practice. It was the physiotherapist at the hospital had rung the practice and said, look, I've got a patient here that's come to me, but he really needs to see a doctor and it's an urgent appointment. So can you squeeze him in, please? And the receptionist immediately thought, oh, health practitioner, he's a physio, he's ringing from the hospital, I'm going to do this. But again, in this particular case, the physiotherapist was just trying to do the right thing by his patient to speed up the process. Because remember, your patients know they can't get in unless they have some sort of special need. So in this case, the patient had said, oh, I can never get in. The physio went, oh, I'll get you in, don't worry. So still important to ask those questions, regardless of who's on the other end of the phone. You ask the questions. Don't get misled by the person who's making the call. Don't be concerned unless it is let's say a specialist who thinks that the patient does need an urgent call, but you still an urgent appointment, but you still need to ask a basic sort of a question. Well, why is it urgent, doctor? This next one, this was when I was doing an accreditation visit. I was really interested in this practice. It was a practice that was set in a university ground. And this was a lecturer called to say they're sending up a student who seems depressed. The student was from China and they hadn't been to the practice before. And they live alone in Australia. So I was really fascinated by this triage protocol because they had sat down and worked out that they had a really high incidence of foreign students with depression and anxiety, and the patients notoriously had no family support. So they made the decision for their practice that that any of the patients that phoned or the lecturers for these students, and they knew their students quite well, these patients were automatically triaged top of the list. So this is highlighting again the importance of you working out what your patient cohort is so that you can manage them the best way that you can. This was an interesting one too. Mother calls, she's got a 5-year-old daughter. The child has a rash all over her body that resembles chickenpox. So this practice had a pregnant receptionist in her early stages of pregnancy. So it required a few more questions, and it was decided that this patient needed to be managed differently. So chickenpox is a really interesting condition. It's very rare these days, but there's still certain pockets of communities that will have outbreaks. And look, chickenpox is an infectious disease, and you just need to treat them like you would a COVID patient. In that you would treat them, in a certain way that they are isolated from the rest of the patients waiting in your waiting room. Interestingly, I was talking to a practice just last week, and they were telling me that a patient was sitting in the car outside the practice, and they said, "I've got an appointment at your practice, but I can't come in because somebody is waiting in the waiting room that I can't be near. I can't see this person, and they can't see me." And the receptionist was remarkable. She just managed the situation so well because she treated that patient like she would an infectious patient that she wanted to keep away from everybody else. So she said, "That's fine. Come around the back. I'll let you in the back door. We'll take you straight into an isolation room." So there's lots of different reasons that you might have a patient give you detail that needs to be treated a little bit different from a normally triaged patient. This was an interesting one as well. This was a patient who arrives for results. She's a bit anxious and has her 3 children with her. They're 6 months, 2 years, and 4 years of age. They're boisterous and loud, and mother's not managing the children very well. So again, it doesn't matter how good your triage protocol is, you're not going to be prepared for something like this. So this, obviously, you need to think outside the box and go, okay, a triage protocol is not going to work here. I need to actually think about what I'm going to do with this patient and with these 3 children so that she can have a proper consult. I remember it's about keeping the patient safe. So the patient needed to get her results, and also giving the doctor the ability to actually spend the time he needs with this patient without having 3 screaming kids, in the consult. So your steps to designing your triage protocol, there's 3 steps. The first one is, what are your columns? We start backwards. So what are your columns? What are the capabilities of your practice? When's your urgent appointment? How are you going to manage that? When is an urgent appointment? Is it now? Is it in the next 4 hours? Is it in the next 8 hours? Is it with a nurse? Is it with the doctor that you've rostered on for urgents that day? How does it work? What are your columns? So this is a typical example of your columns. So you might have dial 000, or you might say, "Doctor will come out and see you right now." You might have a column that's telehealth or a car consult or a consult today. You might have a column that's get the doctor or the nurse in the next available spot. You might have see them this session. You might have something like see them this week, see them in the next fortnight, or see them in 2 months' time. So going back to this, they are your columns. What are your columns? What are you actually going to do in your practice? The next one is, what's in your columns? So remember, we're working backwards. So now we have to decide what goes in our columns. So what do we dial 000 for? Profuse bleeding, heart attack, unable to breathe. When do we do a telehealth? When do we do a backdoor consult? What goes in there? So, and you're not going to put absolutely everything down, but you're going to get a bit of a trend. And this is where your PHN pop gun, or whatever it's called, is going to really help you, because you'll be able to look at what they've got in their columns. And then the last step is, what are your questions? So if we come to here, how are you a patient here? If you've got your books closed, that might be your first question. Are you a child? If you see children straight away, that might be the question. You might ask, is this urgent? Beware with this one, because patients will work out pretty quickly what's urgent. And I've seen it, I've witnessed it, where a patient said, well, what's urgent? And the receptionist said, oh, well, if you're having a heart attack. And he said, I'm having a heart attack. So it can be a bit tricky. You might have, do you have pain? Do you have a cough or high fever? How long have you had the problem? These are all things that will help you work out in which column your person fits. This is the PHM one, which I do love. Do you have an urgent problem? Yes. And then this is where you start doing some of your scanning, if you like, or your screening. So I really like this one. And you can see in their columns, and they've called them category 1, 2, 3, and 4. This is where you make it specific. So what's your category 1? What's that look like? What's category 2 for you? Where does that go? What do you do with them in the practice? Category 3, category 4, and so on. So I really do like this one. That brings me to the end of the presentation. I want you to do one more poll question before I take questions from you. So please answer this.
Okay, let's go.
Do you think your triage policy needs updating? Or are you scratching your heads going, I'm never going to be able to do this?
Well, I think that a lot of people have got a lot from tonight, because we are at 81% yes, and we will make it a priority.
Oh, I'm so proud of you guys.
That means job well done.
Good work. Well, I'll give you a quick summary. Oh, good on you. Oh, I like, some people have said, no, it's very good. We have just done it. That's really good to hear. That's very refreshing. Yeah, it does, but we don't have time. Do you know what? For the people that answered, you don't have time, you just got to make time. I'm so sorry. You do not want to end up with some of the ridiculous claims that we've got to try and defend you about. And it's so time consuming once you have a claim. So let's not put time down as a barrier. So we'll just move on to the last slide. Remember that your triage protocol is never going to be perfect. You're going to have to, you're just going to have a guide and think about the times that it might change. Like it's going to help you make decisions, but you also need to be able to think outside your triage protocol when you get like something from left field. The really important thing is that it does keep everyone doing the same thing. So it stops confusing your patients. If you do it properly, it encourages the appropriate investigative work. So that's what we like to have to show to a regulatory body in case a claim is raised. And I guess the most important thing is it stimulates the awareness for the whole team that the process needs to be taken seriously, because it does. We've had cases now where a receptionist has been sued because they didn't do their job properly. Well, you don't actually sue an individual, but the employer of the receptionist was sued. So, you really, there's a responsibility now for you to be doing your job properly when you're working vicariously for practitioners. Just move on to the next slide, which is our medico-legal advisory service. Look, this number is manned 24/7. But if you have any claims, ring us, talk to us about it so that we can help you get all these defence building blocks in place. If you're a member of ours, you don't even have to have a claim to contact somebody from RAS. Julie will give you the contact details. RAS risk assessment team, that's me and my team. There's about 8 of us working. You can get us to help you. You can get us to review your triage protocol if you'd like us to, and we can help you decide whether or not it's going to cover you if something goes wrong. So that's it from me, ladies and gentlemen. Let's see if we've got any questions.
We do have questions, not many, just 4 questions. And I think the first 2 were answered already by you, but I'll just read them in case we can cover some loose ends. Please talk about triage the teleconsult patients and the patient's complaints to be charged for the teleconsultation. They won't pay for the teleconsultation and they still complain about it. How does it work?
Yeah.
Well,
yeah. So Evelina, look, you know what? We get this all the time. You are the practitioner. You set the rules for what you want the patients to do. So if you're going to do a telehealth consultation, then the patient needs to pay. If you want to contact me, and this isn't about triage, But if you want to contact me directly or my team directly, we can give you some advice on what you can say, how you can take upfront payments and things like that, but not allocate it to a telehealth consult so that you do get payment for this. But you do need to think about how you what a practitioner won't do a telehealth consult on. So, and only practitioners can tell you that. So if you ask them, what would you definitely want a patient to come in for?
Sure. Another one, could you please shed on some light on triage for a solo GP practice? No nurse, no practice manager, just one female GP. How do you prioritize? Prioritize? And I just wanted to add here that after the event, we will send you the resources, and this resource which Angela was showing, this triage chart will be sent as well. And I don't think it is the difference between receptionist or whoever else. You just follow the chart. But what would you say, Angela, on that?
Yep. So solo GPs, congratulations first up for doing it. Oh my God, that's such a tough gig these days. It is tough for solo because you haven't got as, I suppose, as much, there's nowhere you can go. There's just one of you. So what I would do is decide, you can work out when things get crazy, like what days are a particular problem for you. It's often Mondays, and just make sure that you have more free appointments on those days, or not book, from 4 o'clock on those days, so that you can see these urgent patients. I know it's hard because then if you don't have urgent patients, you're not doing anything, but there's plenty, I'm sure, that you can do, such as writing reports or and this is the GP. The GP could write reports or check all their pathology, write any referral letters, do any paperwork that they have to do. But if you're a solo GP, you're going to have to somehow reserve some spots in your appointments, because you do have a responsibility to care for those patients that ring and need you desperately.
Thank you. Have we fulfilled our duty of care when we offer an alternative doctor to a patient asking for an urgent appointment?
Look, certainly you don't have to see a patient if you can't, but you need to be clear why you can't. So, you can say, look, we're fully booked for the day, but this is urgent. So you either need to go to the hospital, or there is another doctor that I know has available appointments. So long as you're referring that and documenting it, because remember, you're only going to get a claim in 6 weeks' time. And by then, if you're lucky, it could be 3 months' time. And by then you will have forgotten what happened. So make sure you document what you've done for this patient.
Where and how would you document it if it's a new patient?
Okay, if it's a new patient, it's probably not as important if it's a new patient, because the medical board would probably sit back and go, you know what, it was a new patient, and they've got a standard protocol for this, which hopefully it's a written protocol. So that would be your evidence as well. But if it's a already registered patient and you're full but they're urgent, you could put it in a note beside their file.
Sure.
How do you do that? Sorry, if like putting a note in when reception aren't able to put notes in clinical records or something, and that ability to be answering the phone and typing. Yep. And
so with both best practice and medical director pracs off, there's a way that you can make a note. A receptionist can make a note and attach it to a patient file. So there is a way to do it without them having access to the patient medical record.
Okay, thank you.
And the last question, favoritism. I've seen receptionists fitting in favorite patients and those that bring box of chocolates for the team. Have you come across those sorts of complaints in Avant?
Yeah, we absolutely have. And I guess the biggest issue with this is that the patient has found a way, they've found a chink in your armor. Look, we don't even play Monopoly without having rules. So why would you work in a practice without having rules and sticking to them? The minute you break your rules, I don't care what the patients bring you that, will entice you to break the rules. As soon as you do that, you lose credibility and the patient will start abusing they're abusing your rules so that they can get what they want. You've got to set the rules and you've got to stick to them. Everybody's got to be on the same page. Everybody's got to be doing the same thing. If you let each other down, you're just going to make a rod for your own back.
I hope that some GPs are listening as well. Flair, it's back to you. Thank you very much, Angela. All the questions are answered.
Right.
Sorry, I had to have a chuckle at that one about, it's a very common one where receptionists have set all the protocol and everything, and you hear about the patient for some reason has the GP's mobile and texts them, and the GP comes out and says, fit this person in with that person.
The first thing I would do if a doctor did that is the minute he was free or she was free, I would walk into their office, shut the door and say, what do you think you're doing? You ask us to administer your practice and now you've undermined us. How do you think that makes us look? If you want us to administer your practice, let us. If you want us to see a patient, and squeeze them in, let us tag their file so this can be done. But you can't be undermining us. We've got to all be working together.
If I knew that 50% of the receptionists that I've worked with and come across, and I've been one myself, had the confidence to do that, that would be pretty impressive.
Yeah, but your manager can. Your manager should. If you're talking about this, the manager should have the courage. That's why you have a practice manager. They need to have the courage to do that, because the patients do this all the time. They're so lovely to the doctor and they're so horrible to the staff. And that's because of the culture in the practice. If we know now that patients have a relationship with the practice, it shouldn't be with the practitioner. It's the practice, because the practice gets sued now and the doctor gets dragged in as well. So the doctors need to understand that you're working vicariously for them, but they need to give you the authority to administer their practice, and they can't undermine you once that's done, or
and the respect as well to reception teams. So maybe if you feel that you can't do that, you could document it, GP fit in patient, then you can, then where you're running late or something else happened. Yeah. But anyway.
It doesn't fix it though, does it?
No.
A lot of the times managers will arrange for us to talk at a doctor's meeting as well. We can do it by webinar or face-to-face, and that works really well to try and drive some change if you'd like to get us to change your doctors as well, because we give real scenarios.
Yeah. So on that note, if you're in your practice, if you don't know if your practice has their business insurance, etc., with Avant, ask your GPs. Ask, hey, are you with Avant? Or hey, are you with Avant? And if they are, then that's going to be your link to be able to get the support. There's the online training modules as well that Avant have for members and their staff, etc. So just ask. So for tonight, I'd just like to thank everyone for taking the time to attend the webinar, and thank you for Bertha for managing us all at the back, and Evelina, and mostly thank you, Angela. We appreciate your time, and I always, and so does Evelina, enjoy your real life stories that you share, and we remember them and share them continuously. So thank you, and just a last reminder to everyone online to receive your certificate of attendance and the resources, etc. Please don't forget to complete the evaluation link that has been sent to you, or you will receive it after tonight's webinar. Thanks, everyone. Thanks, Angela, again.
Thank you. Bye, everybody.
Bye, Julie. Thank you.